Okay. You guys still alive? I mean, this is, I have to admit something. If you feel like you're drinking from a fire hose right now, that's because you are. And I just, you're not nuts. If you feel a little overwhelmed, you should. Everybody, I think, is a little overwhelmed, even nationally. I was in a meeting a week ago, and it was at a meeting in Washington that was called the HCPLAN, the Healthcare Payment Learning and Action Network. And the feds and a bunch of payers are together, and they're talking about this stuff. And one of their biggest concerns is the ability of the provider community to understand and actually quickly transform on this stuff. But there's just this is a lot to swallow right now. So I spent the first presentation kind of talking about the what. So I think everybody's got the message. MACRA's coming. It's going to be taking all these other little science projects they've been trying to convince us of for the last 5 to 10 years. It's going to merge them into one thing, and we're going to have a score. And that score will determine our payment as we go forward. And that set of skills that we have to be able to get a good score will be what is necessary. Those will be the skills that will be necessary for us to survive and thrive in this advanced payment model going forward. So remember, the purpose of TCPI is to help providers thrive in the value-based reimbursement world. So again, MIPS, rung 1 on the ladder. TCPI is to help you do a good job on MIPS, and if you're doing well on the first rung of the ladder, then you logically, when you're ready, move to the next rung of the ladder. Everybody kind of with me on that? That's the what. Now what we got to talk is the how. And we talked a little bit about that in the last presentation. So what I want to do here, Dan, next slide. These objectives, I want to talk about, I want to do 2 things in this oh, by the way, what we're going to do here is we're going to kind of do these rapid fire and then have some table talk, and we're going to hopefully we're going to let you go a little bit early. I know you probably wouldn't be disappointed in that, would you? Okay, I'm going to do my very best. We got a lot of stuff to talk about. Yes. Dan has the slides. Yeah. Welcome to Compass. You get the slides. By the way, before I go any farther, I talked to Tara and Kevin, and there were some. Did you have any comments you want to make before we get going?
I just want to say, thing is that this is overwhelming, like you said, and being your quality advisor, Kevin being quality advisor, we're really here to help you guys take those steps. And if you look at this, it's not as a huge, big project or whatever. If you look at it as little miniature things that you're going to accomplish, we're going to help you sit down, create that project plan for you. You can take little steps, have success with those little steps, celebrate, and really work as a team. And one of the things that Kevin and I really want to be part of that. We're going to be there with you the whole way. We also have some great resources. We've got Patty, we've got Tracy who's in the North Coast Flyo, and they're also going to be resources. So if you're feeling overwhelmed, if you're feeling like, oh my gosh, how am I going to even get this started, lean on us. Okay, that's why we're here. And so, like I said, just don't envision it as this huge, big gamut. We're just going to start little and figure that and move on to the next. So I just wanted to do that.
Yeah, thank you, Tara. That's a really good point. Remember, I said a little bit ago, get comfortable being uncomfortable. That would be one of the things that you need to probably take home or have a T-shirt printed up or something that says that. But get comfortable being uncomfortable would be thought number 1. But thought number 2, and this is really important. So much of what we've done historically has been doing something and then they're going to judge us. And doing something else, they're going to judge us. And I've heard this from CMS multiple times here. There's never been a better time to try to figure this stuff out. This is jump in and try to figure it out. There's never been a better time to look bad than now. Jump in, get the data, figure out where you are so that you can start putting the processes in place to actually improve. The sooner you start, The more overwhelmed you are, fine, great, jump in. And now let's try to figure out how we actually climb out of this deal, okay? So, but one of the things we want to try to do, and you've probably sensed this already, is we've got to kind of build a culture, a learning community. So one of the things I was trying to do earlier, obviously, was get people to cross-pollinate a little bit. So one of the things we're going to consider here is, like, how do I do this junk I don't have any idea how to do? And we're going to have to actually do it together. So I'm going to go through an exercise where we talk about requests and offers and talk about that. I want to describe the Compass PTN resources and structures. One of those include your slides. And then I want to talk about, like, how do we do this stuff? We're going to use a thing called the Modified Breakthrough Series model for how we work together, okay? So I'll describe that, our TCPI timeline, and then we're going to be using data to affect change. So we'll talk about all that stuff. Next slide. Next slide. That's okay. That's okay. This complicated nuclear reactor picture, that's what it looks like or something, but this is a thing called the Modified Breakthrough Series model. This is how has anybody ever seen this before? This is how you do large group come together. Let's figure out how we do this differently, okay? So what you do with this, you identify a group of innovators and you bring them together, okay? So now, first of all, you have to figure out what you want to change. So what we have here is I figure out what I want to do, and then I bring a bunch of people who want to do it, okay? Once I figure out the topic, then I have to kind of have some experts, and then we basically develop the framework of what we want to do differently, okay? So this is kind of like, okay, we want to survive with MACRA, and there's a bunch of junk we got to do differently, and we'll have content that we bring you, and we kind of coach you on that stuff. So we got all that stuff kind of done. We've recruited you. We didn't really give you any pre-work other than come to Cambria, okay? That's kind of where we are right now. And we come together in this thing called a learning session. And this is a learning session, okay? We bring everybody together, and we pour a bunch of junk into your head, okay? And now we're going to leave you. You're going to have all this stuff, and you're going to have new relationships, and you're going to be, hopefully, you're just, when you go to a conference, you hope your brain's a little different shape when you walk out. But now you got to go home, right? And you got to do this junk. So when you go home and do the stuff, you enter what's called an action period. So this is our first learning session, and we're going to have other things, other resources we bring you together, but we'll have another learning community, another learning session next year, and another one after that. That's all we have into the budget, but we're going to have other things where we try to get together and do things, and Dan and the team are going to be kind of coordinating that. But what you do is you bring people together, you send them home to work, and when you're at home, you're doing the PDSA cycles locally, okay? You're running cycles of change. Usually a cycle of change can be anywhere from, it's not like a month isn't a cycle of change. You don't gather enough data, but it could be 3 to 4 months is a cycle. So what we're trying to tell people what you ought to do is think about 4-month periods of change, okay? So you identify your process, and then you're going to gather data, and you're going to say, okay, we're going to map out this process, see how it's working. We're going to gather data for 3 months, 4 months, and then we're going to come together and we're going to say, how's that working for you? And you're going to make changes, and then you're going to do another cycle. Kind of makes sense? Why 4 months? Well, one data point is one data point. 2 data points are like, okay, I don't know what that makes. 3 data points is a trend. That's a line, okay? 4 data points, we give you an extra one. Okay, so the whole point is we're gathering data so that you can kind of say, it's getting better, it's not doing anything, it's getting worse, that doesn't work. So what we do is we go through, we plan, we do, we look at our data, we study, we change our plan, we act, okay, PDSA cycles. Yes? don't look at this as a program I signed up for and now I just come to these. I mean, that's the way we've done things in the past. Look at these now as this is what you have to do. So you come together, and we're going to give you resources today, but now how do you run those PDSA cycles locally? Now, how do I select what I should do? Well, you're going to have to decide what PDSA, what PQRS measures you want to measure. And then you may want to kind of process map things out. What are the processes that actually impact those measures? And then, so you kind of, and that's what your QI advisors are going to help you do is, okay, how do I apply this here? How do I locally do this? What do we want to measure? What should we do? What, you know, and so what these guys are going to help you do is kind of like, okay, what's your world look like? What do you have currently? You know, I would look at it if you have certain measures that you're gathering already. I would start with that. I'd process map it out, and then I'd say, how can we make this better? But then what you're doing is you're going to look at it on a monthly basis. Does that kind of make sense? Sure. Uh-huh. Yep. No. That's actually, this is the first time I've ever had this question, and it's a wonderful question. So let me kind of explain this. Collaboratives, the term collaboratives, the way these were designed with, like the Institute for Healthcare Improvement, were learning collaboratives. Oh, what is truth? How can I find how we might do this differently? Okay, it's like always expanding our knowledge of what's going on. Okay, so it's kind of a learning collaborative. The way I'm looking at what we're doing, there's 3 ways that you actually can impact change. One of them is the academic model, which is finding truth. Okay, so double-blind studies, all that kind of stuff. I can find truth. Then there's the education model, which in the education model is basically spreading truth. But we all know how well that works. How often do you just tell people the right thing and they just do it, right? You guys see that all the time, right? If I just tell my physicians, or we just tell if we just tell them the right thing and they'll do it, right? Wrong. You know, that's why it takes 17 years from the time we identify a best practice to the time it's implemented. So you got the academic model, the education model, and the execution model, which is basically, are you doing this? What we're trying to do here is not find new knowledge, but more find new knowledge about how you do this. We've got the best practices. Yep. No. You got to select what you're going to work on. Well, first of all, let me do this, then you can talk. So I guess what I'm saying, I'm not saying this is the whole group thing, though this is kind of how we're organizing our learning communities. The question is, can you, at your practice, do this? Can you take information and then run serial PDSA cycles and actually do change? And that's what I'm talking about with execution. Can you bring it home? And that's really what this is about, is having the practices be able to bring it home and actually execute on this stuff. It isn't necessarily about creating a big group think on how we're going to do things different, but that could be helpful. But the bigger thing is, when I go home, can I have my practice actually go through serial PDSA cycles and improve the performance as measured by PQRS, meaningful use measures, that'll affect my NIPS scores.
I think you have a really interesting, because of chat, I think you have a really interesting opportunity here to say, we almost have a PTN within a PTN at chat, right? So there are things that collectively, the group of board of directors, and say, well, we are interested in these measures, and so their role is how do we support that, right? And bring the resources
Mm-hmm. Right. Yeah, it's not so much the what, but the how. I guess I'd make 2 points. And, by the way, your comment was really a good one. But again, this is how do we work together to do this stuff differently? This is how we organize ourselves. One of the big things I want to camp on is what Dan just said. Did you notice Dan just said we'll figure it out? Let's basically build a solution that works, and we'll do it. You notice that's what he said, and you notice what I didn't say. I didn't say you got to do it the way I said. Okay, we're here. I got a contract to bring resources, and now you got to tell me what the problems are, and we got to try to figure out how we do it. But and you have a unique situation, and you have a unique situation, and you have everybody's got. So we got to figure out. I can't give you the answer, because there isn't a the answer. It's these guys did this, and this could work. So we try to bring all that together and move down the field together. Okay. And that was a great point. Thank you for because, again, bringing, what we're finding right now is, what did they do in Oklahoma? Georgia did what? What did and actually we've had some interesting, South Dakota did what? So we're finding all kinds of little lessons together. So again, this is not like memorize this and there's a test on it, but this is just a basic model that says 2 things, how we're going to work together kind of as in a community model, serial learning sessions, and then action periods where we have to go home and work. But it also is kind of a model. I can talk to you about how you do things locally. You can talk to people, and then you got to gather data and action periods locally and have those same discussions. Okay. Next slide. Okay. This is going to be kind of a weird series here, but this is really important for you guys to get. You don't know what you don't know. Okay. I mean, we think we do. We have to remember that every ounce of our DNA at this point is a volume-based DNA. So we have to now figure out how we do this differently, and we don't know how to do this. Okay, so I want to kind of talk through how we think about things we don't know how to do. Is that weird enough yet? Okay, so next slide. Knowledge comes in 2 flavors, knowledge that and knowledge how. For example, we know that a bike has 2 wheels and a seat and handlebars and a foot pedal crank system, but it doesn't tell you anything about how to ride the bike. Okay? It's amazing to me when I talk to providers about, we need to move to a value-based reimbursement system. Okay. How many of those value things do I need to do? Okay? And it's basically measuring the value in volume, which is like, you missed it, guys. Okay? So the whole point is, we don't get it. And a lot of the time, I think we know what the value looks like. We know what the bike looks like. Okay? But we don't know how to ride it. And it isn't just doing this, because we actually need to go to the next slide, which is we got to ride hard, fast, and long, and we got to do it relatively soon. So the point is, we're going to have to do this, and we need to figure out how to do this, but we don't know how to do this. So how do we do this? We don't know how to do this. So I want to bring you some knowledge from Deming, who's kind of the godfather of all performance improvement stuff, and he made a couple of statements. One of them is that, first of all, in our world today, all of you represent a complex adaptive system. You are in a system. You are in something where this guy does this guy does this, we gather this information, and then that means that we do this thing. You're in a system currently. You're in it's not saying health system, but like your car is a system. How we got lunch today is a system. Taking a break is a system. There's all these system things that we do. We're in a complex adaptive system, okay? And what the systems do is create aims. And then once we kind of have our aims, then we measure if we made progress on those aims or not. Everybody kind of agree with that? Everybody understand that? Like, you usually have an annual plan, you do it, all that stuff. So we're kind of used to thinking like this, right? Okay? And by the way, every system, you've all heard this quote probably, but every system is perfectly designed to get the results it gets. And what are the results we're getting right now? We're going broke. Okay? So they're basically, we've got to figure out how we do this differently. So how do we do this differently? Next slide. So doing this differently with our current system, if I want to have better value, if I want to be able to do this differently, so if I want to improve the value over time, I want to get better value. So, okay, how am I going to do that? The first thing you're going to say is, well, for me to do that, you're going to have to pay me more. I don't have enough resource in the system currently, right? You guys with me? Well, if you changed our payment, it would, if we had more of these, we could do that better value position, right? So next slide. You gotta think different, and this is going to sound goofy, but this is again Deming. Deming said, systems don't create aims. Aims create systems. Okay. What we're doing right now is we have systems, and we're getting a certain set of results that are not. It's just the way it is, and we can't get any more out of that system. We need to have a different way of doing this. If we're going to do this, we're going to have to have different aims, and the aims will then create new systems. Okay? So where we are is with a healthcare system today, we've got to have a value-based healthcare system, and our volume-based healthcare system won't take us there. We've got to have a value-based healthcare system, and the systems will evolve around those. So next slide. So basically, if we have to, in the value-based system, we want dramatically better value over the same time, but we've got kind of a conundrum here. I ain't got enough resources to do this. I don't know how to get there. I don't have money. How do we do it? We don't know how to do it. Next slide. So what happens is we're going to have to figure it out together. And I know this sounds like kumbaya or something here, but basically, you're going to have to share those best practices. We actually had this discussion just a second ago, where we talked about, well, I actually had this thing and we do this and we learned this and, oh my goodness, it's amazing. We'll find we do this and then we'll go backwards, then we'll go up and then we'll go backwards, and it's going to take all of us kind of moving to get there. But we will figure out a path to get there. We will create a new system to get there, to do that population-based, community-applied stuff. You guys with me on this? Now, does this sound like schmaltzy and Pollyanna enough for you yet? Like, this is great, Tom. This is the psychobabble crap that you're giving me, but I got to go home and run this thing. And I don't think anybody would ever do this, right? We never could execute a system like this, really, this aims-based system. Next slide. Ever seen this guy? Okay. In 1961, President Kennedy basically said we're going to put a man on the moon by the end of the decade. Now, for those of us baby boomers, I was like 6 at the time, and that was so cool. But you got to think back. It wasn't like Kennedy could just call up NASA, because they'd been in existence for 3 years, and just say, roll a Saturn V out onto the pad and let's get to work here, because the Saturn V didn't exist. Okay? I mean, Kennedy, the systems didn't exist. Okay? Matter of fact, I don't think most people understand how big of a leap the thing that Kennedy did was. Because in 1961, there were 2 spacey kind of countries, the United States and Russia, and guess who was ahead? Russia. Okay? Like Russia had a satellite. It was called Sputnik, and it was circling the Earth. Sputnik was about this big, by the way. Okay? Had 4 antennae coming off of it, and it was circling the Earth. And Americans were worried they're going to start dropping things on us. Okay? And they were paranoid. You know what happened with the United States? You know what we had for a space program? About 52% of our rockets just blew up. We couldn't launch anything because they blew up most of the time. Okay? So for Kennedy to do this, to say we're going to dedicate the excellence and do this thing, and then what happened was we actually came up with a space program, and the first thing we had to do was we had to figure out how to do this. Could we get one guy in space? We started with the Redstone rocket, which was something that we used to launch missiles, and we had to build a capsule that we could put a guy in and not have him burn up, okay? And then we launched the first guy into space, Alan Shepard, okay? And you know what he did? He went up, and then he came down, and we pulled him out of the water. Success, right? So then we're going to do it again. So now we have Gus Grissom, and we put him in the capsule again, and we send him up about 4 months later, and he goes up, and he comes down. And we got Gus Grissom, but we lost the craft. We couldn't fish it out. We couldn't execute on the whole system. Well, but we learned a lot. So now we do the next cycle, and the next cycle was John Glenn. John Glenn. There should be like choir music. John Glenn. You know. But John Glenn. And remember, everybody remember what happened with John Glenn? John Glenn went up. And what was so famous about John Glenn? John Glenn circled the earth. John Glenn went around 3 times. And he landed, and we fished him out, and we fished the craft out, and we were off to the races. 4 more Mercury flights. Learned a lot. Went to the Gemini program. 2 people. 2 people. You know what we did in the Gemini program? We had to be able to open the door and let somebody walk around and then come back and repressurize the cabin. So we had to have 2 people in the spacecraft at the same time and not kill each other. That was basic, and it took us about 7 or 8 flights to do that. Ed White, first man to walk in space. Remember that stuff? Okay. Then we came to the Apollo program. 3 people. And we killed 3 people because we burned them up on the craft and the spacecraft on the pad. And we had our problems, but we did it. In July in 1969, we landed 2 guys on the moon, Armstrong and Aldrin. But the whole point is, we did it. We can do this. Have we ever done this before in healthcare? Next slide. I can't remember if I have that on here. No, I don't. Have we done this in healthcare? I described it earlier today. Yes, we did. Partnership for Patients campaign. Partnership for Patients campaign basically said we're going to reduce hospital readmissions by 20% over a 3-year period, and we're going to reduce unintended consequences of care, patient safety. We're going to improve patient safety. We're going to reduce preventable harm by 40%. And again, I talked about this earlier, but we thought we'd maybe save $5 billion. We saved $19 billion. We thought we'd save maybe 40,000 lives. We saved 80,000 lives. And basically, we did. We achieved this stuff. We can build different systems. We can build different systems in healthcare. Next slide. So how are we going to do it? Well, this is one way, is we're going to continue to kind of work together and figure out, we're going to learn from our mistakes, just what you described earlier about, well, gee, this worked here. We're going to try to bring those lessons together, but it's not just going to be cross-pollinating from North Dakota, but we're going to bring in South Dakota. I don't know if you want to do what they say or not, by the way. But North Dakota, South Dakota, Iowa, Nebraska, we're just one PTN, but we've got the Great Lakes, which have, you know, Ohio and Michigan, and we've got other folks. We got all kinds of folks that we're going to be. You're in this learning community, 140,000, trying to figure out how do we actually do this stuff together. Next slide. So that's basically the Compass deal. We're going to be together on this deal. Next slide. And this is what we have to do. And again, just to remind you, process map out. How can we do it different? Use the data to see if we're effective. Hopefully we'll start improving. We'll start improving at a national level, and you're going to get to this point where you're ready to thrive. It's basically, when I take risks, I don't want to lose my backside. Okay? I've got to create a sustainable system that I'm going to be able to keep doing here for North Dakota. Next slide. So I made this point earlier here, but medical home is a big deal. Medical home is, for what we have to do, a medical home is about 40% of where we need to go, but it's the first 40%. So do you guys know much about the history of medical home? I mean, this is actually kind of a big deal. I'm going to just quickly go through it. Next slide. This is not a new term. Medical home was coined in 1967 by the pediatricians. And it was basically, oh, we've got these broken kids, and they go to this specialist, and this specialist, and this specialist, and nobody's coordinating their care. What if we had a medical home for them, pediatrician, what if we had a medical home for them that coordinated all these attributes? And that was the basic concept for a medical home. It kind of sputtered along as a special place to manage, difficult to manage pediatric cases. And in 2002, the American Academy of Pediatrics actually took the medical home model they were using, and they combined it with the chronic care model that Dr. Wagner had proposed. The next slide. Have you guys seen this? The chronic care model? Okay, some of you have, some of you haven't. But again, We talked about doing population-based, community applied. Stick with me on this. There are 4 touch points where we actually have a chance to improve our community health. If we want to get to improved outcomes, we're going to have our patients different. They've got to be informed and activated. What does that mean? Number 1, they better understand their disease. Number 2, they better be motivated by their disease. How many times have we heard our physicians say, if you could just make my patients be compliant, I'd have it done, right? Okay, well, if you talk to your patients in a way that would be engaging to them, rather than just telling them what to do, I mean, there's a whole new science of patient and family engagement that's being developed. We'll talk more about that over time, but the fact is, we've got to build informed and activated patients, persons, communities. Someone's got to do it. Who's going to do it? Prepared and proactive practice teams. That doesn't mean I'm the doctor, do what I say, but it could mean it. It could, go ahead. How do we get them engaged? How do we equip them? Yeah. Well, yeah. 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 Amen, brother. That's right. Yeah. I'm there. Yeah. Yeah. But remember that pie chart with like 70% of it is I can't control it? That's the deal. And guess what? Somebody does control it, and it ain't me. So I got to figure out how I engage them differently. Yeah. They got to do it. Now, the whole point is they're one touch point. Okay? They got to want to, but someone's got to kind of help equip them so that they got to do the want to. And again, what Wagner has described here is, it's interesting. He didn't say, thou shalt do this. He said, we got to have productive interactions. Productive interactions. It's not just office visits. It's productive interactions. It could be talking to a pharmacist, whatever, but we've got to equip them, and we've got to have a prepared and proactive practice team. When I say that medical home is 40% of where we need to go, but it's the first 40%, well, if your practices are requiring the skill set, the basic skills of the medical home, you're going to be a long way on this road, moving down the road there. So again, we got to do this, but we got to do it within an environment. And the environment, the community, the cloud up here is really divided into 2 pieces. And I kind of divide these into, there's the health system, and the health system, think of it as the healthcare providers in your community. It could be your hospital, it could be your long-term care, it could be your pharmacist, but basically what is the care continuum within your community? And then the community at large, bringing together public health, area agencies on aging, all this junk together. There's really kind of 4 touch points. The community resources, the medical resources, and call this the medical neighborhood. I oversimplify and call this the medical home. You can't have a medical neighborhood without medical homes, by the way. You can have all the resources, but if you don't have this prepared and proactive relationship, this isn't going to happen. It just ends up being referral-based care. So you got these 4 pieces of the community, the medical neighborhood, the medical home, and the patient. So that's kind of the chronic care model that was proposed in about 2002 by Wagner. And this model really defines kind of how do we do the community-based care piece. Next slide. So with that input, the pediatricians kind of took that stuff together and it morphed a little farther, and you can see the different components they added, accessibility and continuous care and coordinated and comprehensive and all this stuff. And what happened is the family physicians and the internal medicine guys, the other primary care guys said, wait a minute, this isn't just pediatric, this applies to us as well. This is really good primary care. Next slide. So what happened was in 2007, remember I said we'd gone through this thing with medical home, it was popular and then it lost popularity, and now it's popular again. So in 2007, all the energy came together because the pediatricians, family physicians, the internists, and the osteopaths all got together and said, this is what the medical home should look like. They came up with 7 joint principles, okay? And to date, now it's been endorsed by about 36 different medical specialties. So it's like everybody's kind of going, yeah, that's what makes sense. So what are the components, those 7 principles of a medical home? And these are the words that were used. They were introduced in 2007. Stick with me on this. But personal physician in an ongoing relationship, that's basically accountability. It could be a nurse practitioner, it could be a PA, but someone has a relationship where there's an accountability relationship. Number 2 is it's team-based care. I can't do it all. I'm a family doc, guys. I can't do it all. I got to have somebody else. We've got to have a team-based approach where there's someone's looking at the stuff I can't keep my eyes on. Frankly, I'm a doc. I'm a diagnostician. I'm good at identifying broken things and writing an order to fix them. But I'm not so hot at managing or maintaining a system to keep someone who's broken from getting further broken. That's going to take health coaches, maybe my nursing staff, maybe pharmacists. So there's new ways of thinking about team-based care as we go forward. Whole person orientation rather than just that ear infection that walked in I need to be thinking about, or Mrs. Smith, the diabetic. She needs to be Mrs. Smith, the diabetic, who's Amish, whose husband, whatever. I mean, there are all kinds of factors that determine the compliance of a patient, and we need to figure out how do we start thinking about some of that stuff. Coordinated or integrated care across the system. You saw the chronic care model. We need to start thinking about that. Right now, we have a healthcare system where all of the pieces are operating separately, chasing their own revenue stream, and it's very inefficient, and it's very fragmented. So we need to be thinking, there needs to be some place where we start thinking about how we pull that stuff together. Quality and safety are a hallmark. Oh, we're all quality, aren't we? We're all quality. Well, the fact is, can you measure it? Can you prove your quality? And the fact is, now with PQRS and meaningful use and all this other stuff, that's really where this is going, guys. Now they're going to have measures that we have to start to document for our payment. All of a sudden, they've added teeth to this thing. Enhanced access doesn't mean, what our access currently is I can get you in for a complete physical in 3 months. You know what they call that? I can get you in for a physical in 3 months. For a physician's office, that makes you feel real good. I'm so good, I have that much wait time. You know what that's called? Inventory. I have that many people in the warehouse waiting to see me at some point when I have time to work them in. That's efficient, right? Okay? We got to be thinking about how we do this. How do we create? If you're seeing all your physicals, if you're that far back, do you have access to for 6 days? Oh no. So they'll see my TA. Or better yet, they go to the. That's cool. That's why we're fragmented. Now the last piece, do all these other 6 things, then we'll have payment reflects our value. Okay? Here's the story of the medical home. Introduced in 2007, I was in Iowa. We had a couple of state laws that said we're all this stuff on medical home. What happened was there was this great push to do the top 6 things, so that you could get paid. So how has anybody played the medical home game so far? You know what it's been? The medical home game has been, go do this other stuff and put policies and procedures in place so that you can document that you do this, so you can qualify for it. What HEDIS is a payment. It's basically you qualify to help something data. Anyway, it's basically a payer mechanism that says, check the box, you are qualified, and then you might. And a lot of providers have said over the course of the last 7 to 10 years, well, you haven't been making any difference, so why am I doing all this? So we went from lots of excitement to, well, less excitement. It's interesting, the federal government said, oh my gosh, the medical home, actually, that is where we can go. You know what they just did? Just added macro. Now is going to pay us for quality. Guess what we got to do? Okay, that's really where the game is right now. So the medical home can do a lot of things. That's the basic medical home skill set. It's going to help us with our transition to the hospital. Remember I talked
They're going to be again, activated and engaged. Self-management is going to be huge. Self-management is going to be doing, don't break, and then we actually pause. And it's going to, this is going to get around to coordinate some of this. So, I'm not going to spend a lot of time on a couple of pieces.
Sure what.
Okay, here's some definitions for it. So I talked about medical home, medical neighborhood. Medical home is not a single place or location, but it's a concept. How we do things differently.
I'm not sure.
Medical neighborhood, term that was coined by Elliot Fisher, which basically almost community can include the hospital and all that other stuff. The point is, you can't have them. You don't have units. Next one. ACOs, all of us talk about ACOs, but wider than organizations, they're accountable for cost. Okay. What's the difference between an ACO and an MCO?
Okay.
An accountable care organization, where they're driving us to do this, basically the wider community together. The wider community comes together to accept. What's an MCO? A payer. Basically writes together a steps of this for a population and the payer. The difference between an ACO and an MCO. Does somebody accept the risk and tell you what you're going to do? Or does the provider community actually accept the risk and work on redesigning care? Okay? Do you get the difference between provider-led and payer-led here? Okay? Which one do you think is going to create the most sustainable and innovative solutions? If we are the ones who are actually, remember the joy in the work? We actually give a rip about what we're doing. If we're actually designing that, it's probably going to be better structured, more innovative, and more sustainable than the payers are just saying, we're not going to pay for that stuff. Okay? ACO, MCO. Next slide. So the medical home, okay, we'll just skip these. Basically, there's several slides here that basically say, does the medical home work? And we've had about 7 years of experiments with Nebraska, Colorado, some others. It basically works it up with the federal government has said, this is going to be the basis on the new payment system. So we're going to have prepared proactive practices actually driving care. Next slide. So, I told you we're going to do how. I spent a lot of time talking about we don't know what we don't know. I spent a lot of time talking about medical home. So now I'm going to tell you about TCPI. So you're here. Why are we here? Well, you've kind of been prepared. I stretched your brain a little bit. I think you understand we're all ready to sing Kumbaya or whatever. But so I want to tell you a little bit about this. Next slide. We're doing this. Next slide. What's CMS asking us to do? A, move toward a PCMH model. It doesn't mean go get level 3 HEDIS certification. I don't care if you do that or not. You'll have to decide if that's the right thing to do for your practice. The decision point on that is you have a payer who's going to pay you differently. If you do, great. If you don't, and if getting HEDIS certified at a higher level helps you drive your local culture, great. But it isn't about the HEDIS certification. It's about the ability to engage patients differently and execute. So move toward a patient-centered medical home model, which means basically deploy those 7 principles. Measure quality on a monthly basis. You're going to have to do that for PQRS anyway. What we're going to ask you to do is do this stuff, and then we're going to bring a coach in to kind of say, how's that working for you? And how did you do this differently? And here's how we could probably help. We're asking you to come together. We're asking you to enroll in this thing, but also engage, and then share with each other. Work on transforming as you go forward. And basically, we have been asked as Compass PTN to assess our progress. So I'm going to be taking all of our numbers here, and I got to communicate back up to CMS about if this is working. So some of the data we're going to be gathering, we're talking about gathering data. We're going to be taking your data, smushing it together in a big pile, and then building lessons. We're going to take that to CMS. So with that, next slide. There are two important things for you to know. There's a thing called the TCPI change package, and then there's the TCPI practice assessment tool. These are two pieces that are complementary. The practice assessment tool is something that you need to fill out. You need to assess your practice within, theoretically, the first 30 days of enrollment. And that's like your starting point. That's your point A. So we need to get that on you so we know what we have. Once we have that, this practice assessment tool yokes with this change package that's been written, and we can basically say, where are there opportunities? Okay, let's pull some stuff from the change package and we can help you get better. Okay, so practice assessment tool, change package, and then about every 6 months you're going to fill out the practice assessment tool again. Okay, so we're going to kind of go through and we're going to see how, go through the journey. Where are we? Do a bunch of junk, see how we're doing. Do a bunch of junk, see how we're doing. It's going to be cyclical as we move forward. You guys with me so far? So the change package. What's in this magic change package? And again, the change package is this is a national product. It's been built by a national content developer, and it basically aligns the practice assessment tool. It's organized into kind of a goals, objectives, and tactics model, which is there are 3 big goals that we're going to achieve. And then under each one of the goals are a series of objectives, and then under each objective some tactics. I'm not going to go through all of the detail on this thing. I know you're probably going, thank you, Lord. But what we are going to do is I want to tell you about the goals of the change package. So the next slide. There are 3 goals for the change package. Number 1, enhance person and family-centered care. So we got to figure out how we talk to people differently. And that's a whole new science. So there's going to be a lot of information coming about how do we actually engage our patients as partners in our care. Number 2, we've got to provide continuous but data-driven quality improvement. We're going to have to use data to affect change. So there's going to be a lot of, you're going to have to report this stuff, so you may as well get used to it. But let's take the data that you have and start helping you use it to improve your data. And then finally, probably most importantly, I got to be in business at the end of this thing. So this will have coaching with regard to how do we infuse sustainability into this as we go forward. I want to talk about each one of these goals in a little bit of detail. This one, this is Hawaii. About, I don't know, 6 or 7 years ago, my wife and I went to Hawaii, and I used this slide to depict our relationship with our patients. When I talk to my patients, usually I'm talking to my patients, and do I really hear them say anything? Not necessarily. So this is my patient and family engagement slide that I've used for years. I did this, the funny story on this one is that I did this slide 2 or 3 years ago, and I was really proud of this. Really proud. We had a patient safety conference, and we brought in patients. Okay? We brought in hospitals that were doing patient and family engagement councils. We had them share their best practices. We had a panel of 3 folks, 2 big health systems talking about the patient and family engagement councils, and then we brought in a patient. Still remember this guy. It was a patient from Omaha, and we got up there and we were so proud. It was our patient safety conference, and I got up there and did a bunch of generations and talked about how we talk to our patients like this. And then the first person talked from Legion Health System, talked about what they were doing with the patient and family engagement council, and then somebody from another system got up and talked about how wonderful we are with engaging our patients differently. And then the patient got up and he was kind of saying, first of all, he was talking about it. He says, we as the patients actually have a different perspective. We don't always see things in the same way that you do. And it's really important to include us. And I was very happy to be included today. But I want to underscore how much we see things that you don't see. And he said, I just love this slide, Dr. Evans. This is just wonderful. But he said, have you ever noticed, has anybody else noticed that Dr. Evans has 3 legs in that picture? And I'm going, and no one had ever pointed that out before. I happened to be standing by some stupid post, but he said, we see things that you don't see. And I only bring this slide up to just remind you that, you know, we got to remember to engage our patients in different ways because they do things we don't see. Anyway, let's go to the next one. Patient and family engagement, patient-centered care. There are a lot of basics that we're going to have to learn with regard to patient and family engagement. I mentioned multiple times there's involved in science. Team-based relationships, there will be scores on these things. That, you know, remember those 5 phases that they're going to have for us? They have actual scores on each of those areas. So the activation, the assessment tool will have ways that we can kind of grade where we are on things. And then these will be different content packages that we can kind of bring in and try to do locally. Population management, practices, community partner, coordinated care delivery, organized evidence-based care, and enhanced access will all be subcategories of this. Next category is going to be on quality, continuous quality-driven improvement, engaged and committed leadership. Whoa, that's a good one. You're going to teach us how to have leadership. What does that mean? That doesn't mean you go to the Lions Club, but it means that we're going to have to figure out different ways that we engage our clinicians and actually have them begin to assume some leadership on some of this stuff. So engaged and committed leadership. You know what engaged and committed leadership usually means? Eliminate the barriers. That's the most important thing that leadership does, is find ways, get the things out of the way so we can actually free people up and solve the problem. Quality improvement strategy, supporting a culture of quality and safety, that's going to be one of your big challenges. How do we actually do this and make it how we do it in this clinic? How do we create that culture of change? Transparent measurements and monitoring. Transparent. Watch my mouth. Transparent. Okay? Right now, when we talk about transparency, it's usually, oh, we don't do it. You know, we're not very transparent with it. Why? You ever think about that? Why aren't we transparent usually? Because the way they've used data with us in the past is to always beat us over the head or compare us against somebody else and say, you're bad and you're not. Or you're bad and you're bad, you're just less bad. It's like, we don't need that. What we need is, where am I and how do I get someplace else? You can't do it unless you're using the data. You have to be honest. You need to be honest with your team. You have your clinic understand where we are. We got problems, we can talk about it. And we need to figure out, because you may find that the person who helps you solve your problem is actually a medical assistant. I mean, you're going to have to have the whole team unyoked solving your problems. And then optimal use of health information technology. You know, I hate to really, sing dance and so on, but the fact of the matter is, we can't continue to chart offs for everything that we do. We're going to have automated systems to gather that information. So next one. And then the last category is sustainable business. Sustainable business operations, strategic use. This is weird. You're telling me this? We got to have some discussions about strategic use of practice revenue. How do we do this so we can create a sustainable system? Workplace vitality, enjoying the work, capability to analyze and document value. This is a biggie, guys. Because we don't do this right now. How do we document value right now? How many patients did we see? Okay? Not how many people actually got better. How well did we manage our population of diabetics? Okay? We're going to have to find new ways of doing this stuff. Efficiency of operations. If we can't squeeze the waste out of our system, our waste is going to kill us. Okay? So this is kind of the stuff that's in the assessment tool. Yeah.
One thing, I just think the key word here is sustainable, because, I'm looking at all of this, like I was first helping people, and now, and, it's really going to be so important for these practices to figure out those processes, put this stuff in place, because, we're there to help you now. That's not to say we're going to be there, hopefully we are there, they have to learn how to do it.
Yeah.
And to do it well, and just to not
it's so important that, that's a really good point. Teach a man to fish and eats for a lifetime versus give a man a fish today and eats today. You know, we've got, this is about teaching our clinics how to fish. And you're gonna have to fish. And I know we've never fished before, but you gotta learn how to fish. And they're gonna measure you on that. So that's a great point. It's about kind of back to execution. Next slide. So we got to get to this. We can't do this unless we know where we're starting from. So we're going to go with the practice assessment tool. Next slide. Please, without almost done. Practice assessment tool. This is now the second version. But we haven't even the second version is short. It's about 40 questions, but it's basically a tool that helps you try to figure out where you are. It aligns to the change package. You're going to have to do about every 6 months. But it's going to help you define your improvement pathway. Remember, every practice is going to be unique. It is important to know that there's a primary care practice assessment tool and a specialty practice assessment tool. So we're not asking PNT folks to do what the primary care is. Okay? Next slide. So this is kind of how we're going forward together. We talked about, and again, this slide should be meaning more and more to you each time you see it. Okay? Next slide. Okay, that's the end of that presentation. Comments? You guys kind of asked questions as we went through. So what I'd like to have you do is we're going to do another table talk here. So what is your clinic doing currently to kind of prepare for medical home? And we can do this. What are you guys doing? You're not going to move. What are you doing to prepare for to develop medical home capability right now? Say that again. Congratulations. Yeah. How's it working for you?
Encouraged.
Yeah. How's it working? You what?
We're just now moving forward.
Okay. But how's it working at level 2 for you?
To be honest, to have an opportunity.
Right. You know, so often when we do these things, we gather some data, and what we do is we gather some data, and then we put it in a file, and then we keep doing what we're doing, and then we gather some more data, and put it in a file. I've got a slide here later that I talk about, but the secret isn't getting the data. The secret is using the data. One of the most important things you're going to have to begin to do now is as we get the data, now we need to convene a discussion about the data. Okay. Wednesday noon, we're going to discuss the data and see where we are. And it's an all hands meeting. You got to be there. Some drug guy brings in lunch or something. But you know, you basically have to talk about it and then say, okay, what did we learn? How do we go forward? But it's basically creating that discussion. Other comments or questions? Yeah.
We told them that we have to be part of the normal doing. We can't be medical home for 4 years.
Yeah, talk to the OB-GYN said that they're primary care.
Yeah, and so one of the things that we with the conference last month.
My wife would, by the way, say that her OB-GYN is her primary care.
Exactly, and so we actually over the last month, so I went back and asked our docs. You know, there's things that we do in an OB-GYN setting that really is population management. We get station diabetes.
Right.
But ACOG, the organization, specialty, puts out, I believe it's over 30 of these bulletins essentially that really could be kind of a population management criteria. And so we're just starting to, I got them to give me about 7 or 8 potential criteria that we can use as a way to improve care within our care. It's something that, so we're starting to crawl maybe. But we're having to think about our role in population management differently as clinicians and practitioners, because what
it's interesting. First of all, I want to encourage you. We're just beginning to crawl. Everybody's just beginning to crawl. Okay? OB-GYN before you feel like you're insane. OB-GYN is the one specialty that defines itself when it's convenient as a primary care or as a specialist or as a super subspecialist, depending on the doc. So it's just broad. And what you're going to find is that depending on your practice, what they choose to do, you're going to find segments that you work with. And again, what I would do with you, I would recommend you're still going to have to do patient and family engagement. You're still going to have to kind of learn how to do all that, John. However, what I would do is I would kind of say, as a practice, if we have to demonstrate value, I would, again, do your specialty-based practice assessment tool, look at your PQRS measures that pertain to OB, select your work set, and go back to that.
Well, I feel like I'm commonly known to listen to you because I really see the value in just our principle of improve system. We should try to do that. But even teaching your example of the space program, and that was investment of hundreds of millions of dollars. I mean, the division was passed. And what I'm hearing you also say, the pie is going to stay the same. So we have to reach for the moon, but yet the pie is going to be the same. How do we create a sustainable system with teams where you have to actually invest some resources? But yet I'm not seeing the insurance companies on the side.
Yeah.
Come alongside to give us some benefits. So I feel like I don't know what to do.
Yeah. Well, I guess when I look at provider-led, either we do this or we're always going to be jerked around by somebody else's payment system stuff. I don't think, maybe I'm Pollyanna, but if we're going to transform the system, I'd rather the provider community working to transform the system than someone else. And with regard to the space program, that's a very good point. But it's more about, we didn't have a clue what to do. It was, it's about, we created, I know there was a cash infusion, but it was more about the knowledge base. We had no idea. And we had, and right now, every bit of our DNA is volume-based, which basically means all of us are out just generating how many widgets we possibly can. And we're going to have to figure out how we actually block and tackle together.
I think we have that vision of the response system.
And again, the reason I do what I do, and I actually am here doing what I do, is we live in a demographically sparse environment. Iowa, the Dakotas, we've got a lot of really good people who really want to do the right thing, but there's not enough. It's not like we can make it up on margin here, because we just don't have that many widgets. So we have to do whatever we do well. Luckily, we have this upper Midwestern work ethic and an ability to communicate and a willingness to work together. And I personally think a lot of the solutions for the national healthcare system are going to come out of us. So I know you're depressed. Yeah. Yeah.
How many other people in the room feel like leaving? Right, caught in the middle, not exactly sure which way we're going. Nobody knows?
Well, I think, I wouldn't say caught in the middle. I would say there's clearly a recognition of how big the task is. And I see you as just going, just a big lift.
I think it's the right thing to do.
It's just a big lift. This is a comment I usually make when I'm closing, that I'm going to make this year. What we are living in a special and unique time. This is, it would be so much easier to be 10 years ago. It would be, because we could always just print more money and make it work, but we can't then. And this quote I usually use when I close one of my conferences is that I believe that providers will look back on this day. Providers in 30 years, they're going to laud us or they're going to damn us for the decisions we made. And we got to figure out how we create a sustainable system. The stuff we're doing right now is going to be around for a long, long time. Yep.
So I apologize I missed this, but I am curious how this skills
next presentation.
Oh, that's.
Seriously, that's the next thing. 406. What? Is it okay if we just keep blasting here? Let's do that.
Give me a few seconds
Data effect change.
to get that up.
Oh. Here. Okay.
And you can actually probably take that mic off, Tom. I think the battery died on it, so we're picking it up off this one now.
So,
We'll get there. Yep. It's just going to take me a second to.
While they're getting that ready, I just want to let everybody know that there's a great resource available to you as Compass PTN members. It's healthcarecommunities.org, and we highly encourage all of your staff to sign up for it because Compass PTN is posting recorded stuff out there under the PTN area. CMS is posting stuff out there. You can find a change package there. And it's future collaborations will happen via healthcarecommunities.org. So get everybody in your organization to sign up.
okay. What time am I supposed to be on? 7? You guys still alive? You guys okay? Okay.
Charge on, he says.
Next slide. I want to talk about data, and it ain't easy. You guys understand that, right? We talk about the complexity and challenges of different data types, sources, etc. This is really kind of a passion presentation. I talked already about using data for comparative reporting, performance improvement. Describe the flow of data that we're going to do with Compass, which is really kind of the point we're making. And consider some clinical strategies. We're not going to spend a lot of time on that one. That's why. Okay. Data. I'm a family doc. I've been doing this stuff since like 1986. I've heard everything about data. You can't say that. My data is not. How often have you guys heard that? You get information, you bring it to the docs, and the first word is, well, you can't say that about the data. The data's crap. Anybody ever heard that? Right? Okay. Well, let's talk about why. Okay. So data actually comes from there are different ways of cutting the data. There's where did we get the data, and it's basically the clinical data versus the claims data. Everybody understands the difference between those, right? Claims data is how many payment episodes I had versus clinical data is what do I have in my charts. And the problem is now we have what do I have in my charts, some of which is auto-populated or in a PDF format, and other stuff I got to pull out. I can't use it, but basically clinical data versus claims data. And the standard saw for physicians is last claims data is crap. But we actually know a lot more about claims data now, and we can drop all the conclusions from that. There's scope. Scope is okay. What I really want to know is did it make a difference? That's great. But some of the time I'm making a difference, but there's factor A, B, and C, all of which are processes that will affect this piece, and I can't even measure this. As a matter of fact, I may not be able to measure the outcomes because I don't see that often enough, so I have a low N. Or it could be so complex. So we often measure processes that will affect outcomes. Okay, so that's another dichotomy. Then there's a purpose. Are we using the data to actually compare myself against somebody else, which the payers do constantly? They will put our comparative reporting out there to create pressure on us to try to reduce costs. Okay? The problem is we got to improve performance. So the comparative data is great. Where I put on the scatter plot is interesting, but I actually want to move my dot from here up. So comparative reporting looks at me in the scatter plot, how I compare to everybody else, but performance improvement, performance data is me using this to actually continue to do cycles to improve my position within the scatter plot. Kind of makes sense? You guys with me? So I kind of look at this, and I kind of say next slide, it's kind of like a Rubik's Cube. And what data is important? And the answer is, it depends. How do you cut it? Some of the time you want clinical data, sometimes it's claims data. Which one is acceptable? Are you using it for processes or outcomes. And this is really me only saying it's not going to be perfect. This discussion around the data, when you talk to your docs, you're just going to have to say, and the answer is it depends. And the data is good enough, but we need to talk about what the data really means. Next slide. So back to this thing, you've seen it already. What CMS needs to do, again, PCMH, but again, measure quality on a monthly basis, and then we want to use this to improve. Next slide. One of the things that and this is a very quick section, but one of the things that we're doing is we're basically going to take you where you are. What data do you have? What are you reporting? Now, theoretically, you've got to start reporting to PQRS. So what do you have for PQRS? And now let's back into that. So what are you doing to improve that data? And that's kind of what we're going to work with you on, taking your data where you are and kind of moving forward. Next slide. When you report data to us, I'm going to kind of process map out how you do this. You can have an electronic health record. You cannot have an electronic health record and still send us data. Okay? But so what we're going to do, there's three ways we can receive the data. Either if you've got an electronic health record and it can just populate the data. Correct. But if you can't, then some folks will have registries that will take a whole bunch of patients and then we'll create a numerator and denominator from that. We'll take numerator and denominator populations. Or we can actually, if you want to go through and do chart by chart by chart, and put stuff percentage of that information, you can take it that way. So we can take it in those three different ways you can submit the data. We're going to be aggregating the data. This is not like, we're not sending, this information is not going to CMS to be used for payment, to use for judgment. This is basically used for learning. That's the whole point of the TCPI piece. This is in the Innovation Center. This is about how do we do this, how do we find models that work. We're creating a model where we take your data and we coach you with regard to your own performance, try to help you improve it. So, and your data is going to be entered through a web portal. Having it at patient level, we can, but you don't have to. Okay. And what we're doing, the collaborative, Compass, we aren't doing all the data stuff. We have subcontracted with a QIO named Intelligent, which is QIO in Iowa and Colorado and Illinois. They have a tool that they developed called QualiTrack. So that would be the mechanism that receives your data and it aggregates data from all over Compass into one big pile, and then we can do analytics on that. Quality improvement organization. So like local, like the other guys at your table. Okay. Yes. Okay. Either. Kind of what works. You have to decide what works for you.
No.
It depends on the EMR.
Well,
the answer is it depends.
Yeah. Let me clarify that a little bit, right? If you can submit a QRDA3, and I know that if you're submitting to different forms, you can probably submit a QRDA3. There are some very technical issues that we just waste a lot of time with. But according to the 2014 certification criteria, if you run a 2014 certified product, it can produce a QRDA3. Now, you may have to work with your vendor. Yes, and there are some specific problems with that. If Kevin could describe those to you. So Success EHS is one of those that can produce it, QRDA3. I forget the technical piece of that was that they didn't want to do. Weren't they the ones that?
Yeah, basically what Greenway told me or told this client was that to meet the certification standards, they just had to prove that they had the ability to do security. They didn't have to actually produce one. Greenway has no intention of threatening them, is what they call it.
And I think the bottom line on that, Shelley, is what Tom is saying is that we sort of recognize that there are going to be those kinds of problems. And so we have some abilities. We can help batch upload. We can do things like that. there's a manual process if you get to that point. We could even take data from somebody who has not used it. Obviously, that's not the preferred way. I mean, you'd love to build an interface and be doing asynchronous transfers and just not ever have to worry about it again. And quite honestly, by 2025, if we can't be doing that, the whole thing is not going to work, right? But I think acknowledging that right now, you know, even with the big push with RECs and the big push with incentive programs and getting systems in place, Tom describes that as flawed. I absolutely, yeah, that is flawed. Part of the reason is because it shoved a lot of money at the problem, right? And vendors took advantage of that, quite frankly, and you know, that's the thing that's being dealt with at the ONC and the national level too, with the data blocking work that's happening. And
now, if you were to correct, you guys look at the overlap between DBS and the mechanisms and whether for helping us take like every mechanism or I mean, I know they just came out and said, but
First of all, that would only make too much sense. But we begin with the end in mind.
Yeah. If you guys started doing that work, if you can work with health centers that are areas that have particular
Intelligent is doing a lot of that work right now.
What?
Intelligent is doing a lot of that work right now as they write the architecture. That's supposed to be done theoretically by the end. They have different modules that have kind of been built, but the point on that one is that, well, I would love to say it's all perfect, but it's all kind of getting there. You know, I back to what you said, Dan. By 2025, it doesn't work. Well, we look how much farther we are down the road than we were in 2005.
oh, right, absolutely. Yeah.
We're so much farther down the road. They put a lot of the stuff in 2005 in place. That was when the first, I mean, Bush really entered. He took the. I look at HIT and the quality improvements, two rails to the train track. Bush took one, Obama took a different one, but they basically got to have both to get there. And a lot of it was basically shell down.
Sure.
Now, the interesting thing is, all the incentive was to build the capacity for the system, but nobody basically came up with design principles for what it's supposed to be about. I mean, what's supposed to go across the health information technology system? Quality data. We haven't gelled on that until now. So this next 5 years is going to be a lot of that, merging the two pieces. So the next slide. This is kind of a pictorial version, kind of the flow of the data. You and your clinic are going to have the data. You're going to be doing PDSA cycles. But you're going to be basically using this data to feed your local work. Back to that comment about if you're not, it's one thing to have the data, it's another thing to use it. But then if you generate data, and again, the data is going to be sent over to Intelligent, which is our data vendor. It's going to be PQRS for clinical stuff, a resource, meaningful use. Those will be the components going through. And like I said earlier, we can receive it in 3 ways: EHR, numerator, denominator, or patient specific. We get the information, or Intelligent gets the information, so we send it to Intelligent through the web portal. That information then goes to us. We have to feed our CMS relationships. We have to aggregate the information and take it out to CMS. We'll be using this information to kind of feed our learning communities. So how are we doing, folks? What have we learned together? And then technical assistance is to feed our in-the-field discussions. Okay? And then basically your performance feedback coming back to kind of feed your PDSA cycles. Yes?
On the previous slide, there was a note that Intelligence will be helping track PDSA. Is it just the data?
Oh, wonderful point. Wonderful point. PDSA work plan tracking is a new thing that just got added that they learned that from the hospital engagement network. Okay? What happened was you build your work plan and then you and then you do your cycle and then you get the numbers and then you make a few changes, then you do your cycle and then you get the numbers and you make. Well, what happened was just like Did anybody remember what we did 2 cycles back? So what this does is you'll enter your work plan, it'll be captured, and then we make some changes, and we do our cycle, but it'll be caught. And we'll be able to say, oh, that worked. Oh, that didn't work. So it's basically, this is now a place where we can track the performance improvements we go forward. Does that kind of make sense? Okay. Next slide. And next. Okay. So this is a list of preliminary measures. I have to tell you, when we wrote this thing, the whole discussion has evolved so much farther from what we wrote in the grants and where it is today. So I don't even know what we're going to measure. I mean, a lot of the stuff it's going to be PQRS measures. These are just examples of both value measures. Some of these are utilization measures. Some of these are PQRS measures. But these are examples, if you will. PQRS 001 on diabetes, hypertension, 30-day all-cause readmission rates, and other we track. These measures, I would strongly recommend you identify PQRS measures and you go with those. Now, on utilization, how many of you are familiar with choosing wisely? Okay. Choosing Wisely is a national program that basically looks at stewardship, looks at how effectively are we delivering care. It looks at dumb things that we do and measures if we should do them or not. The low back pain thing that I mentioned earlier today is an example of the Choosing Wisely initiative. There are other things. There are giving antibiotics for a viral infection. And these are all kind of things like we kind of go, oh, you shouldn't do that, but we were incented to do it in the past. And our patients expect us to, but we're delivering crappy medicine. So now we have this two-edged sword of my patient will be pissed off if I don't do it, patient satisfaction, versus doing crappy medicine. And Choosing Wisely basically is a program that works. All these medical specialties have identified somewhere between 5 and 15 different processes that we should not do, and then has measures assigned with them. And we strongly believe that CMS is going to be picking up those evidence-based, those are all based on evidence-based medicine, don't do this junk. So what we've embraced is using several Choosing Wisely initiatives, like don't get a head CT for someone with uncomplicated migraines, okay? Or overuse of diagnostic imaging for the first time somebody has a fainting spell, get a CAT scan looking for a brain tumor. You actually do a history and say, gee, did she stand up suddenly and then she stand up? So it's basically like using your common sense. And basically you can go back to the patients and tell them, look, the evidence says this is not good medicine. This is what we should be doing. So these are kind of examples of some of the measures. Okay? Or what? Yeah, every PTN can do whatever they want, but we're basically going. I mean, we're really pretty teach to the test. It's like there are lots of different PTNs out there, but the way we look at it, we're going into resource-challenged environments. What do we need to do to both survive, create population-based community-applied care, and sustainability? Okay, next slide. So these are just kind of some summary points on data, on how you should do it. Number one, don't go out and reinvent the wheel. And it's something we learned real quick. We've been doing data for 10 years now at the Collaborative. We do the public reporting for Iowa. What we learned real fast was we can come up with the very best measure in the world if you want to. No one's going to listen to what Iowa says. Okay? We're just a dinky state. Even if it's a better measure, states that have a lot more in will get the attention. And if you guys are in the same boat, this isn't about finding the perfect measure. Our strength in the upper Midwest, we don't have to be the smartest, we just have to out-execute it. So what we're going to do is we're just going to go out and do it better than everybody else. So that's what we need to do. Follow the national standards, follow the money. Remember I said teach to the test. PQRS, meaningful use, utilization measures. Let's figure out what they're going to pay us for. Let's get equipped for that. Number 3, beware of the reporting burden. We really wherever we possibly can, we want to use data that we already have. So, I mean, no one can go out and hire 19 more people to collect data, even if it was in our charts. So we have to be thinking about where can we get data we already have to populate. Number 4, keep it simple. You don't need 19 measures. You probably need 4 measures and a regular discussion around those 4 measures, and you will get a lot more engagement, a lot more culture change locally if you keep it focused and simple and drive it that way. Focus on execution. Remember I said academic, education, and execution? What's in it for me? What does this make a difference? Is this actionable? Look at things that aren't just academic crap that somebody can write an article about. Does this actually improve patient care? Is this something I can do about? Don't do something about. Don't focus on a lot of measures that are like esoteric. The providers are going to go, well, that's nice, but it doesn't really help me. And then finally, that last point there, having data is not using data. I can't stress enough. There are many, many, many folks that gather data that they can then give to their boards or somebody else, and it's great, and it doesn't do anything. And basically, you've got to get the data and then figure out your clinical strategies to get it before your care teams and your providers to actually execute changes in the way there's needed. That's the secret. Okay? Questions? Yes.
So on the utilization data, like the claims-based data, how are you getting that and how are you reporting that?
Well, you're going to be reporting it to intelligence.
I need a reporter every day.
No. Well, that's if you chose to report.
What?
That's a menu. You didn't have to do that one.
I guess what I'm wondering about is like.
What are you going to? Okay. How are you going to report to PQRS?
Okay.
Oh, you don't have to right now because you're a federally qualified.
Right, but also, I'm not 100% sure, but my understanding would be QRS probably clinic-based data. And then as you move up into more or ACO technology, that's when you're going to need more of the system data around utilization, et cetera. So I guess what I'm trying to find out is, are you just giving me my data back to me in a comparison kind of way, or are you adding something else to the picture?
We'll be getting your data. We're going to be trending your data out. You're going to be able to compare your data against other folks. Hopefully, we're going to have state. It depends on how we're able to get the cut. It depends on the size of the group. But theoretically, I'd like to either get state or region and then national comparisons. But that's kind of where we are at this point. Now that I've said all of that, and it depends on what CMS tells us. Because CMS is not at that stage yet. What? Medicare what?
Is not giving you any data.
No. This is the most important thing with this is you're going to have to get the data. The question is, are you using the data to affect change? So that's kind of what we're going to be working with you on, is using your data to try to help you improve. And I'm going to turn it back over to data geeks and make sure I haven't said anything that I shouldn't have said. Dan, Kevin, Sarah.
Well, I know that the QIO can access some of that. They can help with QR, I'm not familiar with that before, but the QIOs can get some of that.
Are you looking at QRUR? Are you guys looking at your QRUR?
I don't know.
Okay.
That's PQRS lingo,
Right.
right? The utilization reports, and again, one of the first things we need to do for FQHC is right? What is that equivalent report that you get? How are they slicing that?
Yeah.
And that I think is one of the places that QIO is really, and they are specifically in their 11th scope of work, and Tracy, you can take a couple minutes at some point and sort of say what the QIOs are supposed to do in their scope of work to assist this process. I don't know if you're prepared. I don't want to put you on the spot, but if you want to take the floor for a minute or two and just say, this is kind of what we are supposed to do in this whole process.
Which I personally think you will. I think I think there's going to be some change. I personally think they're not going to allow a two-tier system going forward. We're going to have some new way to participate. I guess let me play in here for a second. This is a perfect discussion of the comparative reporting versus performance improvements of the data. And what you have, the only way you meet the data today is I got to send this in, and I already know how I compare, and I understand that. question is, does any of that stuff actually help you improve? And this is about blocking and tackling different, and actually developing those change skills within the clinic system. And what I heard you say, and I'm not knocking anything you said, because your current data source, everything's kind of English compared to Morgan. And frankly, you don't have a real incentive right now with the current payment methodologies to do that differently. But I personally think you will. And I mean, the purpose of this program is to get data and then to use it locally to change your skill set and your culture so that you can do things different. And theoretically, you're going to pay differently at some point. Everybody else has got to go there. You're not there right now. But the question is, so I guess if you want, I can see your point if you don't think you're going to have to do any performance improvement. But it's a bit of... No,
I wasn't saying I don't believe. I mean, I was just trying to understand what the value is added to this network on the data. So if I'm understanding it right, we can follow our information, we can pull 4 measures where we want to look at, pull information, and there's something there. That way, we pull together there and say, guys, we're doing something wrong here. What we're doing is we're working to help us figure it out. We're going to try to figure out what we're doing wrong, help us with our IT guys, and say, we're putting in here, electronic medical is wrong, like not telling it, or something. And I think that monitors we get that you guys can help figure out why we're taking it.
This program is about bringing you resources to try to improve.
But I think there were resources that change. I think resources that change. They're going to be the one line. Yes.
Like I say,
We're going to have resources come back. There's some way or another. This is a whole system of change that we need to do. How do you do this? So you are best at it. So that's their first attempt. I would imagine over time it's developed that person who would have changed there. Not only about the uses of the line, all of them. You're in the line, that's what you're doing. We're coming nationally. They were changing the way we're doing it. We're going to critical down, we're going to go right.
yeah.
These are the capital ones. We're at the capital ones.
Yeah, I don't have the answer. I just know where it's going at this point. Well,
yes, I think that's the point. We have to know.
I personally agree with you. And another example of this is like the critical access hospitals. The critical access hospitals today, we have all the PPS hospitals that are paid. They have all these payment incentives in place now that they're not going to get paid for this, they're not going to get paid for this, they're not going to get paid for this. There are all these unintended consequence things up here. The PPS hospitals have got to meet those pieces. And the critical access hospitals are paid on a cost basis. But the whole point is, the PPS hospitals have to do this. These guys don't. But at some point, what you're going to end up, you better be executing at that level, because if you don't, at some point you now have a 2-tiered healthcare system. And the finance thing for me on that one is, if I got a 2-tiered healthcare system and someone's going to be doing revenue contraction, I wonder who we should get rid of. Probably the low quality guys. So I'm just thinking, I don't think we can hide behind that. I think everybody's got it. So I agree with you. I think puck's going over there. We got to figure it out. Yeah.
But I think another thing too is, once PCMH is, there are other third-party payers that are we're very much going to go with PCMH.
I totally agree with you.
Yeah, CPC Plus is doing that now.
Yeah, how things have happened in the past has been, and I think I talked about this earlier, but the provider community comes up with new ideas and they start charging, and first nobody pays for it. But the first ones who pay for it is the commercials, and then Medicaid because of state pressure, and then finally CMS to do it. What's happened now CMS is saying, we got to break this train. They've gone to the front, and they're saying, we got to do this different now. The providers have to respond to that. Commercials, why would I not go along with where everybody else is going and reduce my cost? They're the most nimble of the bunch. They'll be there first, and then Medicaid will be coming along after that. But CMS, we've never seen this day, folks. CMS is driving the truck. Instead of CMS sitting back going, well, why not do that because we're CMS. Now they're driving the truck. Other questions? You know, it's 4:42, and I do not want to carry you long, but I want to turn it back over and see if Dan or Tara or Kevin or anybody, do you guys from HealthPOINT have any messages or any comments you want to make to the group?
I guess just from a messaging standpoint, I just want to reiterate that we will meet you where you are, right? Yeah. And we have committed, Tom has committed, IEC has committed, and had conversations with CMS about, we're not going to be able to say, you've got to report on these 6 or these 8 or these 9 or whatever. I mean, there are other things out there driving it, right? I mean, NACRA is driving that. There's going to be an expectation from the meaningful use component of NACRA, PQRS, and those pieces. But from our perspective today, if you can report on 1 or 2 things that you say, we have really, you know, we think these are our areas, right, we could really improve on, those are the ones that we want data on, so that we can then say, yes, absolutely, you're right. Why are we not improving cycle over cycle? Right? What resources can we bring to either from the QIO or quality improvement advisors to get in there and sort of, I use the term poking with a pencil a lot of times, right? And sometimes that's what it takes. And as you look at those numbers, and if you're not improving on those 1 or 2, we are way better off moving you along on those 1 or 2 and teaching you how to move yourself along on the other 6 later, right? And so that's really what we're going to be about. If you can give us 1, we're going to take 1. If you say, I can't give you anything,
but we're going to ask you to use it.
Yeah, then
we're
going
to
say,
have discussions about it and process map it out and how's that working for you. And if you can only do 1, good. You just do 1, but let's get good, and then we'll add another, and we'll figure out how we do this. This is about improvement. This is about embedding performance improvement skills within our cultures and learning how to play a new game. Sorry, Dan.
No. That's absolutely that's the point, right? It's good for them to hear that from you because that is, if you can't do 1 today, we need to figure out how to do 1. Right? I mean, we need to get that 1. And if you think about the reporting burden, if you're going to report manually on only 1 measure, even if it's monthly, it's not really the worst thing in the world compared to the resources that you get back to build on.
And I find that 1 though, make sure it's 1 that's actionable and impactful.
Yeah.
Make sure it matters to you, and let's help you get better. It's about helping you get better.
And that's really all I want to say.
Well, it's close to 4:45, so I just want to thank you guys for your attention today. I am really impressed with you guys spending a week and a half, and I have time on an extra half a day. So, thanks for being here.